Welcome to DentLinks. My name is George Tawil, and I'm very happy to present you this case that we have treated recently, a patient suffering from severe resorption of the maxilla, and that we treated with a bar-supported overdenture. And I call this a simple and a complex case, and you will see why. Management of a severely deficient maxilla can be a real problem. Can be managed by reconstructive surgery using either autogenous bone graft or bone substitutes, guided bone regeneration, bilateral sinus lifting, and finally an implant-supported fixed or removable prosthesis. But this also takes a lot of time and efforts, and oftentimes the patient presenting with such disability are elderly patients with little physical, emotional, and financial resources that allows them to undergo sophisticated advanced surgical treatments. So oftentimes the solution is what is the most simple way to approach the problem, at the same time solving the problem and giving the patient what is the most important thing is function. Patients often present with a very unstable prosthesis, unable to chew, having social problems interacting with people with a prosthesis that falls every time they speak. And of course, eating becomes a problem. Chewing on this prosthesis is practically impossible. In the present situation, the patient that presented born in 1946, a female patient, has a very severe systemic condition that is called fibromyalgia. It's a pain processing disorder that causes widespread musculoskeletal pain throughout the body, also fatigue and sleep problems. So the patient is, from the start, having problem dealing with pain. The patient is on antidepressant, is emotionally and mentally stressed. She's been rehabilitated in the mandible with a Neuron 4 supported prosthesis several years ago and happy with the function in the lower jaw. But however, she's suffering from a very severe unstable maxillary denture that is impairing her speech, her chewing capacity, and also her social life. She's unable to undertake a complex surgical treatment, not only for psychological and physical reasons, but also for financial reasons. She has no financial resources that allows her to go through an advanced surgical treatment. So let's see what she's presenting with. She has this prosthesis in the lower jaw, a Neuron 4 implant-supported prosthesis. In the upper jaw, a full denture. The maxilla has resorbed quite severely in the centripetal fashion, as it usually occurs in this kind of resorptive process. The anterior-posterior relationship between the jaw remains acceptable for an implant-supported prosthesis. Now, this is a situation with quite a flabby tissues in the anterior part of the maxilla and practically non-existent ridge. And when we look at the panoramic X-ray, we see that she has quite a pneumatized sinuses on both sides and limited amount of bone available in the anterior part of the maxilla. So we took a cone beam CT only to realize that she has only two areas in the canine fossa where we can have some bone available for the placement of two implants, about 10 to 11.5 millimeters in height. And when we analyze a little bit more thoroughly the sites, we realize that the bone, this is the remaining ridge, that is quite resorbed. But if we approach the case from the maxilla towards the canine fossa, we have approximately 11.5 millimeters, and the angle of approach is in approximately 30 degrees. This is the right side. Shall we do it freehand, or shall we use guided surgery for that? Now, using guided surgery is also problematic because it is not very possible, given the amount of bone that is left, to stabilize the appliance and do the drilling in an effective way. There is no bone available to stabilize the guide on the maxillary bone, and doing this would have also been relatively, to a certain amount, incorrect. So the other option is to use the freehand approach. Now, how to approach the case in a way that we can place these implants using whatever we have as references in the mouth and orient ourselves 30 degrees posteriorly and superiorly in order to place these implants. So when we analyze the situation, we have come to realize that if we go from the midline sideways and move about 8 millimeters from the midline sideways and taking a 30-degree orientation superiorly and posteriorly, we'll be able to place the implant. This surgery is difficult because of the precision that we have to work with a margin of error about 3 to 4 degrees orientation in the posterior and superior part. So we decided to do the case freehand, and we did a limited incision in the anterior maxilla. We located the incisive canal. We took a reference on the midline, moved 8 millimeter sideways, and we took a 30 degrees orientation posteriorly and superiorly and placed and did a drilling with a 2 millimeter twist drill. And then we took an X-ray to confirm that we have taken the proper direction, and we continued the drilling and placed the implants. The flaps were sutured back in place, and we sent the patient home for about 2 months. 2 months later, we needed to approach the case again to do the abutment connection. We took a scan 2 months later to see how the implants were integrating, and then we happily found out that the implants were placed in the proper direction, as you can see here. We benefited from practically the maximum amount of bone that we could have. In such case, the bone quality was good, and initially we had an excellent primary stability of 40 newtons. So 2 months later, we were ready to do the abutment connection and connect the implants. Now, this is the healing then 2 months later. At this stage, we did again an incision on the ridge, and we removed the cover screws and connected the healing abutment. And about a week later, you can appreciate the healing at this stage here. It is still healing because we had to do quite an amount of gingivectomy in order to reach the top of the implant. We're here in the parietal mucosa, and the thickness of the tissues were about 6 to 7 millimeters. So that is a week later. We connected 2-angle abutment to correct the angulation, as you can see here. And then our prosthodontist took the plaster impression, fabricated a bar on the 2 implant with a distal extension, and this is at the time of the prosthesis try-in, the occlusal try-in. The lower prosthesis, mandibular prosthesis, needed to be changed, but for financial reason this was not possible. So we wanted to do the upper and the lower jaw, but this was not possible again. So this is the try-in. At the time we connected the bar, the prosthodontic connected the bar and tried the prosthesis and determined the proper occlusal vertical dimension, the freeway space, the midline, and the stability and the aesthetic also of this appliance. And when he found out that the patient was happy and all the references were correct, then he prepared a mill bar. This is the mill bar that is placed in the patient's mouth, and the prosthesis were stabilized with three clips. This is the final prosthesis in the mouth. The patient is very happy. This is the panoramic X-ray at the time. We placed the prosthesis, and the patient smiled, happy to function with. When she first had something to eat, she was so happy, but the prosthesis was stable. She could speak, she could eat properly, and that solves the problem in a more or less simple and, I should say, extremely effective way. Thank you for your attention.